You're now listening to the Adiel Gorel Show. Each episode, I'll bring you the latest news from my discussions with top health and wellness experts so that you can bring yourself into better health. Today, on the Adiel Gorel Show.
Google Zdeblick spine fusion. Zdeblick spine fusion article. You will see an article that says prospective randomized study of lumbar fusion. You will see that's been published in 1993. You will see as of today that's been referenced in 1,123 articles. I mean, that's a known fact. That's the Google. That's the most referenced article in the entire world of spine surgery. And you will see that it says preliminary result. And I'm like, how is that possible?
Okay, so given we are dealing with this field easily for 40 years, why hasn't it become a residency all its own, maybe 4 or 5 years instead of the 1 year?
That's a very difficult question to answer, but I can tell you right now, the whispers are there. There have been talks about that, but the orthopedic surgery and neurosurgery, they don't want to let go of that. It's a power grab. It's a turf war. So I actually I listened to a lecture specifically for that question. Like, say, for example, general surgery. When the field of surgery started, we call general surgery, you had all these plastic surgery, vascular surgery, heart surgery. These are all under one general surgery in 1920s, 30s or so. As these specialties branched off, plastic surgery, vascular surgery, colorectal surgery, general surgery was more accepting in them becoming independent. That has not happened in the world of spine surgery. Orthopedic surgery just doesn't want to let go of spine surgery, but the time has come, and that's what you see. What the problem has caused, because the training is a joke. It really is a joke. 1 year, it's nothing. It's like,
yeah, I understand, but from the standpoint of a layperson, an ignoramus in this field, when I think about a neurosurgeon transitioning to spine surgery, to me it doesn't jive, because this is spine surgery based on how you described it is really working on bone, and it sounds like the background that you have is more appropriate for that.
well, that's something that needs to be discussed. Spine is a mechanical device. That's all it is. So I have a much easier time to explain what I'm doing to a carpenter or a mechanic as opposed to another doctor. So we never sat down and said, okay, let's see how this device works. What are the forces? What are the counter forces? What is the lever arm? We never sat down and did that. We just started putting the screws and just took off with it. So, and I've done that for the first time. It's part of the book that I wrote, Corporate Spine. In one chapter, I talk about biomechanics. I sat down and wrote biomechanics specific to spine. So that's the big argument, saying that, would you rather go from orthopedic side or would you go to the neuro side? Well, I'm here to tell you that this is all I can say, and I'm an orthopedic surgeon. I don't want to cause a turf war or anything like that. But I have to say that I have a much easier time explaining this to a neurosurgeon, because their brain is fresh. Has not been pre-filled with wrong biomechanics, as opposed to an orthopedic surgeon that they are convinced that solution to any problem to bone is a screw. If you say anything but screw, that they just don't. It's going to be a bigger screw. The answer is either a bigger screw and a longer screw. That's the only thing you can do with a screw, either bigger or longer. That's so either going to go bigger or longer.
Okay, so you described before your invention.
Yes.
Which are the plates that sit on the very hard bone and basically kind of tie it in a Ziploc.
Correct.
at least to the uninitiated ear, it sounded really good because you explain about the inside of those bones that is very soft and mushy, and when people age, they get even more so. So what's the status of this? Where is this now? What you invented?
Well, this is the situation. I've explained this in my book. I was developing this device, and I was developing all by myself. I hired two biomechanic specialists, and we developed it. And we had a working prototype. You have the picture, and this is this is the device itself. So it's a flat plate that sits against the lamina. And those straps, they are not regular straps. They are stronger than same size cable. They are composed of this material we call Dyneema. Dyneema is a basically special type of plastic, very dense. Uh, a lot of things, Dyneema, we're seeing it in a lot of like climbing ropes becoming Dyneema. They're just, or winches, in Australia, for example, winches, they're all Dyneema now because they're so strong. So, so when people see strap, they're just like, oh my God, it's like, what is a strap? So I had to tell them that, no, these are special straps. They were not available 10 years ago. That's one thing. Two, somehow I cannot make orthopedic surgeons to understand this concept. When I approach them and I say, my device is stronger than the screw, they laugh at me. They want to just tear me into pieces. Say, how do you even say that the strap is stronger than the screw? And I say, look, the argument is very simple. You can make the screw as strong as it can hold this building. But if you put it in junk, you got junk. You got nothing. My device is not as strong as a screw, but I'm holding on to a strong bone. So, the chain is as strong as it's this weakest link. So if you put an inside bone and that bone is just, then you got nothing basically. But back to the conversation that you made. So people probably might want to know, well, why didn't you raise this issue? I do for the last 4 or 5 years, except up until COVID. But up until COVID, let's say 2016 till 2020, I would go to these conferences, I would get up and I would just let them have it. I remember in 2016, I got up in American Academy of Orthopedic Surgeons in a special meeting in the spine surgeons. And I said, we have created an alternate matrix for ourselves. When you guys present patients in these conferences, you present your best outcome, your best x-rays, your best performance. So when we come to these conferences, we feel like, wow, everything works great. And then we go to our office, practice the medicine, and our patients are going to pain management, screws are coming out. So by this presenting only good outcomes, you've created this abyss, this matrix that things are good, and that's not right. Because why people do not present their problems? Because they're working with a company. The company doesn't want you to present the bad results. That's the problem. So the companies have actually surrounded us with this aura that you can't talk about the bad results when you go to these conferences, because then they're not going to support you. And that's a big problem. Now let's talk about my device. So what I'm saying is that I would get up in conference and I say this. I'm not a keyboard warrior. I go to these conferences and I said. So one time I got up and I said the question about screws. The gentleman in the panel up front said, "We've shown many times that the screws work." I said, "It doesn't exist. Go look. It does not exist. What you're saying, evidence that screws work, it doesn't exist." So I said, "Well, what do you say?" I said, "Well, I'm working on a device." He said, "Oh, so you want to promote your device?" So I came back from the meeting and I took that to the heart. I said, you know what? When I started this research and development, my goal was to invent a device that will bring me financial, gain. I wanted to get a nice vacation home, nice car or something like that. But then what happens that ended in a bigger problem and a bigger problem and a bigger problem. And then now it's become so big that it's not about me anymore. It's not about one person getting a nice car or a nice house. It's about the entire specialty of medicine. We're talking about the entire population on Earth getting proper care. So I said, you know what? I'm not going to develop that device anymore. So there's no question in terms of where my loyalties are. The first thing that we need to do, we got to start from beginning. We got to do this right for the people. We got to start from beginning. We got to fix this from beginning. Do the uh, right training, and then we can sit down and talk what to do next. I even talked about, it's like maybe even I donate the proceeds of my device because, to be honest, after this has happened, my goals are much bigger now. I mean, it's not about buying a house or thing. It's about retraining so patients can get appropriate uh, treatments, so the spine surgery can move in the right direction. So that's where we stand now.
Well, I'm glad you addressed it because otherwise that was my next question, is to take away the filter that somebody would say, yeah, he's just trying to push his device. So now you've already, addressed it. It seems to me, based on the realities you're describing, that if your device has a chance to be out there and be used, is you probably want to sell it or at least do a joint venture with a large pharmaceutical, with a large manufacturer, and then they will know how to push it.
At this point, as I said, I have put that to the side. I'm not even worried about it. I'm not even thinking about it. The problem is much bigger to be sidestepped, basically. We got to sit down and say, what are we? Because let me tell you this, my wife never wanted me to write this book. My wife was like, you have a great career. We have a great life. You're just going to ruin it. I said, once I found this out, I can't live with myself anymore. And I told that guy in the conference, I said, it's not that I have a device that I want to promote that. No, because I was developing this device, I went back and looked at these and I found these things out. You guys haven't. I'm the first person to do it because I was inventing this. So that's how it happened. And once that happens, hey, I gotta fix it from the beginning. Let me tell you, if you right now, Google Zdeblick spine fusion, Zdeblick spine fusion article, you will see an article that says prospective randomized study of lumbar fusion. You will see that's been published in 1993. You will see as of today that's been referenced in 1,123 articles. I mean, that's a known fact. That's the Google. That's the most referenced article in the entire world of spine surgery. And you will see that it says preliminary result. And I'm like, how is that possible? How can you explain a preliminary report, an unfinished report, being the most referenced paper in the entire field? You can't go on like this. I mean, I didn't just write this book. I didn't come up with this. I thought about this for 3 years. Am I doing the right thing? Because you got to understand, as I explained, world of spine surgery went through a great trauma in 1990s because of the pedicle screw. There were multiple lawsuits. There were multiple investigations by United States Senate. All these leaders of the field, forefathers of spine surgery, they had to go and testify in the United States Senate. So I told myself, I'm going to open all these old wounds for what? Maybe I'm doing the wrong thing. Am I doing the right thing? And I kept telling myself, and I said, no. I came to the conclusion, no, you can't have a preliminary report by a guy that's very questionable as the anchor of your entire specialty. That doesn't make sense. And there was a problem that we went through trauma in 1990s. We didn't address it. All we did and swept it under the rug. Problem didn't go away. We just swept it under the rug and kept going.
Okay, so I understand that. Now let's bring it down so our viewers and listeners can benefit. Right now, today, a patient comes to you and you see that they need that kind of surgery. They need a fusion of sorts.
Yes.
What would you use?
Standard of care. I will use the screws. Absolutely.
You will use the screws?
Absolutely.
Okay, now, there is always the debate between whether surgery is even necessary, whether there could be some other methodologies or movement patterns that people can learn to cope with a disc that is faulty, or, I mean, given that you're using the standard of care, and given that you're not a big proponent of the efficacy of the standard of care, would you be more inclined to let the patient research some alternatives before the surgery?
Yes, absolutely. And that's exactly why I wrote this book. That's exactly. If a patient comes to me and he said, what you want to do, I'll say this, the standard of care. But if he tells me, look, I've read your book, I've done my research, whatever you do, do not use those screws. Because there's a very important concept I need patients to understand. Because some people don't understand this concept, and it's very important. The research doesn't say that the spine surgery doesn't work. The research says that the spine surgery is working. If you compare the people, they have really bad pain, they've tried everything and nothing worked. So if they make them wait, as opposed to people who get surgery, people who got surgery, they did get better. But also the research says that the addition of these screws didn't earn them any more benefit. That's what the research says. So research says that the cheap surgeries are as good as the more expensive surgeries.
When you say cheap, you mean fusion?
Fusion surgery, yes. So fusion surgery works, except addition of the screws doesn't add any benefit.
Okay, so wait a second. So if a patient comes to you today, why wouldn't you jump back in time and use fusion, no screws?
You can. As a matter of fact, to make things a little bit more complex, you asked me a very difficult question to answer. Now, the pedicle screw is a very large screw that gets inserted into the vertebrae. Okay, so when you fuse in the vertebrae, potentially you have 4 screws, 2 in the bottom, 2 on top, connected with a rod. Okay, but there is another screw that's a much smaller screw, much cheaper screw. They call it the laminar screw. That just like this, like a screw right here, gets inserted into the facet joint. The research says that works as good as the pedicle screw. So I would say probably I will use that smaller screw. But of course, now if the patient says I don't want screw, I'm like, that's good. If you say you don't want it, then I'm good with that. But I cannot tell you that you shouldn't use it, because I got to practice standard of care. But if you tell me that you don't want that screw in your body, I'm all for it. It's your decision.
I understand. So your invention, has it been taken far enough so it can be used in surgery, or it's not there?
No, it's a very complex device. I always tell people that it's very easy to make a complex device that has to do a complex task. But at the same time, it's super complex to make an easy device, simple device that can do a complex task. So that's what we're doing. We're trying to build a device that's simple, but it can immobilize the vertebrae in a 3-dimensional space. So that's a very complex task. So it's super complex. And I would say 90% of it's done, but that 10% still, and I gotta admit that I'm an open book. I never say, hey, talk big and no delivery. The biggest step hasn't been done, which is to use it in a patient. It's a huge step between have a device that works in the laboratory and actually have a device that works in the patient. That's a huge step, because you can have a good device that works great, but it's a headache for the patient to implant it, or it causes complications. Then that's not going to work. I've had those devices. I was like, oh my God, wow, let's use it. And I had a problem in surgery. I'm like, oh no, you can't do this. That's going to be frustrating for the surgeon.
Okay, so given the parameters within which you can speak, what advice would you give to a person who may be facing spinal surgery?
The whole reason I am doing this, I want people to aware what is going on. This is, and I'll explain, I'll get to that. Let me explain something, and I'll get back to what you just said. When you go to these spine surgery conferences, sometimes in late 1990s, somebody got up in these conferences and said, oh, there's a plenty of evidence that shows these screws work. Then 6 months later, somebody who had listened to that lecture got up and said, oh, there's plenty of evidence. And then 6 months later, the guy who's listened to these two guys got up and said, so within the next decade, it's like, oh yeah, there's plenty of evidence that the screws work. In reality, it doesn't. So all the surgeons now think that there is plenty of evidence that these screws work. So one thing that I want patients to do, to question the surgeons, so the surgeons can go back and look at the literature. You know what I'm dealing with? Let me explain to you a story. I was in 2016 North American Spine Society, and I got up, and I didn't have the knowledge that I have now. So at that time, I got up and I said, we have all these papers that says screws don't work. So what is going on? And gentlemen in the panel said, well, we know that. And then we did some studies later on. We found that they do work. And I didn't want to get in a fight. I wanted to say, well, why didn't you publish that? But I didn't want to get into a fight, because it's a fight. When you question screws, it's a big fight. So I said, okay. I sat down. 10 minutes later, 20 minutes later, I was in line to get a cup of coffee. There was a gentleman behind me, a very established surgeon. I was talking to a drug rep, an instrument rep, and he introduced me to him. And he said, oh, Dr. Aslie doesn't like the screws. And he said, oh, you're the gentleman that made that comment about the screws. Well, I just want to tell you that you're very wrong. Everybody is welcome to their opinion, but you're very wrong. I said, it's not about me. I'm not saying it. The research, our published papers said that it doesn't work. He goes, I know. I published those papers. Those are my patients. I'm like, yeah, what's your name? He told me his name. I had the papers in my hand. He was the 5th author in the 2nd paper that I had. He said, see, that's me. I'm like, okay, well, let's read your paper. At the end, he said, based on the evidence, current evidence, we do not recommend routine use of pedicle screws. He looked at it and said, that's wrong. And he walked away. That's what I'm dealing with.
Wow.
That's what I'm dealing with.
That was his paper.
Yes. He was the 5th.
He was talking about his own paper.
He was the 5th author, his paper. Yes. It happened to me. This is not a story I heard from somebody. This happened to me. That's what I say, people. This is what I'm dealing with. So I want the patients to question the surgeons, so surgeons can go and do this research and find out we've been duped. We've been lied to. And then that way, then we can sit down and figure out where to go from here. Because I really don't think the surgeons are crooks. I really don't. I can't speak for all of the surgeons, but I truly believe good chunk of my friends, good chunk of my colleagues, we really have the best for the patients at our heart. Except that we've been misled, especially the way that the companies have bought out very few of these surgeons, and the companies have put this culture, it has inserted into cultures around us that we can't question anything,
So one of the takeaways that I get is, again, as a non-medical person, and I invite you to jump out of how steeped you are in surgery and go out a little bit, is my takeaway is to postpone and avoid as much as possible spinal surgery, because maybe those things that you're describing will be resolved in 10 or 20 or 30 years, but until then, so what could be other modalities? I mean, I'm just throwing names, acupuncture, Feldenkrais, movement training. What could delay and prolong spine relative health before the last resort of surgery is needed?
Right. And that's exactly what I want my patients to understand. At least once a week, maybe twice a month, patients come to me. It was very frequent in 2010s, will show me a modality, a very cold room or ozone injection stuff, do you believe in this? Do you believe in that? Well, I'm different with other surgeons. Some of the surgeons I know, like, no, nothing works. And that's how I was trained. I'm a very open-minded guy. And that's one of the reasons that I came upon this, I tell my patients, I believe in everything. Everything you show me, Do it. If it works for you, that's all I care. If it doesn't work for you, then hey, you tried it, as long as it's not super expensive. So I believe in those things. And the notion of, do you do surgery or do you do anything else should not even exist. You do those things, anything but surgery. If you tried everything, there's absolutely no other modality that you can do, and only thing that you've left with surgery, then we're going to have to do surgery. A lot of my patients sit down, they ask me, we heard surgery does this, we heard surgery stiffens your back, we heard surgery leads to another surgery, and we heard this and that, like whole 5 questions. I say, and I answer them. I answer every single one of them because I have to answer it as a doctor. And at the end, I tell them, look, this is how it goes. You go as far as you can go to a point that you can't go anymore. At that point, then we're going to have to do the surgery. And what comes after, it is what it is. We're going to have to deal with it at that time. And, the stuff that you said in terms of pain management therapy, I like every single one of them. Like when I was trained, and let me tell you one thing that I need the audience of this podcast to understand. This is super important for people to understand. When you ask a specialist what they think of other modality, you're not going to get an accurate answer. For example, I was trained in my residency that, physical therapy doesn't work. What is chiropractic care? They don't know what they're doing. Oh, surgery works. We know it works. We do it all the time, So when I started my practice, I was running away from chiropractors in town. I was like, what do these guys want? Being an open-minded guy, after 5 years, I said, well, let me figure out what these guys are doing. So I started befriending the chiropractors. And then what I found out, I felt really stupid. I found out that what they do is great. It's wonderful. And this is what it hit me. As a specialist, you see people that always had the other modality and they didn't get better. Because if they had that modality, they got better. Why would they come and see you? So I see all the people who had chiropractic care and didn't get better. Because if they did get better, why would they come and see me? So now I always tell people, I said, I had to defend chiropractors in front of my surgeon friends, and then I have to defend surgery in front of my chiropractor friends because chiropractors think surgery doesn't work. So, and I always
right. So for the benefit of our viewers and listeners, can you tell me the name of your book?
The name of the book is Corporate Spine. So this is the corporate spine. And it's 8 chapters. Now, there are 2 parts to it. The first 4 chapters, I just didn't want to have a book to just complain about things. So I wanted to I really think spine surgeons haven't done themselves a favor to actually educate the public in terms of what we can and what we can't do, what we have available to us and what we don't. So I wanted the patients to understand what we go through when we talk about surgery, evaluate the patient for surgery and no surgery. So the first 4 chapters are written for people to understand what we go through spine surgery. Then the chapters 5 to 8 is about how the world of spine surgery has been influenced by companies that they have control over the so-called leaders of the field, basically. And that has to stop. It just got to stop. It can't go on like this.
So what I'm hearing is if somebody has tried other, avenues, they resort as a final step to go to surgery, they should probably read that book before they go, or at least research, look up, and then come to their surgeon well equipped with some good questions.
Correct. And I promise you, you're going to know more about spine surgery than probably your surgeon. Read that book and then make that decision if I'm right about that or not. I'm not going to say, of course, that,
All right. Well, Dr. Aslie, I know we can talk for 5 hours.
Sure.
You are exploding with good information, but I want to thank you for taking the time to be here with us today. And maybe we'll see you again in the future.
I really
much.
appreciate giving me a chance to advocate for my patients, for people. I really appreciate that, and thanks for giving me the chance. Thank you.
Thanks a lot.
Thank you.
Thank you for joining me today for the second part of our amazing interview. If you didn't catch part 1, don't miss out. The link is in the description below for you. And be sure to click the subscribe button for more videos.